right?
Yes, we are.
Okay, you have the floor.
So Pauline and I are family physicians from Toronto. And as we've just heard in our plenary talks this afternoon, primary care is foundational to an integrated system, but there's actually no recipe book to design it. We want to tell you a little bit about Central Toronto, and then Pauline's going to tell you about our primary care strategy. So the central part of Toronto has 1.2 million people. There are 17 acute hospitals, as well as specialized and chronic care hospitals. And some of our acute care hospitals have highly specialized care and serve the entire province. And we also have serve regional populations. There are 1,300 family physicians, but they're mostly unorganized. They're in solo by themselves or in groups. Some have some nurses or nurse practitioners, but they have all different payment mechanisms. And we've realized that we need a better integrated primary care system in order to integrate with the bigger system. So Pauline's going to share a little bit about our co-design.
Thank you, Jocelyn. This is a bottom-up approach in that we really felt that we were going to meet the needs of our local physicians, and we really had to engage them early on in designing the system and using data and analytics to understand the population needs at the local level, having various levels of engagement, both locally and regionally, with a range of providers and delivery partners. And very importantly, our local health authority was extremely generous in providing the local infrastructure, which meant each sub-region had a primary care lead. I was the one for downtown Toronto with a project management team and a local governance structure, which really allowed active involvement of the physicians in our neighborhoods. And as well as that, we would meet with the local community providers and hospitals to make sure we were aligning with the rest of the system. Jocelyn will talk to you about how we worked with our academic partners to identify population gaps and building on what we heard from the frontline physicians and those demographics, investing wisely on where we could start to co-design the system and develop new programs. And of course, using metrics to continue to monitor our progress. So the underlying premise, of course, is that those who know the system best, know what needs to be changed, are the ones that we need to consult, and that they really need the supports and resources to facilitate the change. So the primary care clinical leads worked with a local hospital resource partner, and we set up these primary and community care committees that brought those range of providers to sit on those committees to really participate very actively in designing and implementing new initiatives. We started with a real disadvantage. Our Ontario Medical Association was in fractious conversation with the government. We had not had a physician service agreement, and they actively campaigned with their membership to stay away from the health authority, who were seen as an arm of the government. But we persisted. We felt that as long as we could show that we were making good on our deliverables, that eventually we would start to see a groundswell of support, and that's in fact what happened. We had structured engagement opportunities around key services. We offered a continued medical education. Each sub-region sent out a newsletter. We even went door to door and called and got emails and made sure that we let people know what were some of the services and programs that were being rolled out in their local neighborhoods. We used surveys, and then we eventually had providers actively involved in our advisory committees. Eventually, the engagement spread to involve a range of local health system providers, the community care providers, as well as patients and caregivers. So this continuum is basically, it's based on the International Association for Public Participation, that you may be well aware of. And of course, we needed to start with those who really had not much to do with primary care integration with the local health authority, and just get their attention by reaching out to them, making sure we had their emails or we had their addresses, because some of them still rely on snail mail, And then moving to that, to maintaining their attention. So giving them platforms that they can inform the initiatives that we were rolling out, that we could consult with them to make sure that we were course correcting if it did not meet their needs. And then moving to a higher order, maintaining their engagement by actively involving them in actual planning and implementation, with a smaller amount involved in decision-making bodies and being empowered. So these broad-based consultations involved patients and providers to really look at where were the population health needs and how would we best address them. There was an overarching mission, which was to co-design and deliver an integrated, coordinated, person-centered primary health care system. A tall order, but we were all very committed to it. The goals under that system were improved access to a range of sectors: primary care, interprofessional care, because there was real inequity as to who had access to team-based care and who didn't, and specialist care. Improved service integration so that primary care was integrating with other parts of the sectors, and increased system efficiency so that there were improved care transitions when patients left the hospital, and also that we were enhancing the use of digital connections. With the data and with the voices from the front line, we determined that there were 5 priority projects to focus on: attaching patients who didn't have primary care providers, improving the access for many more physicians to interprofessional teams, improving wait times and access to specialist consultations, making sure family physicians had what they needed when patients left hospital in terms of transitions in care and discharge planning, and onboarding physicians to secure communications so that they could really engage within the circle of care. So I'll turn it back to Jocelyn to talk about the data.
Thanks, Pauline. We realized that having data was incredibly important, not only to engage our primary care providers and our community providers, but to keep them engaged. Data would help us have a language to understand where we needed to work and how we needed to do it. So we used data from multiple databases on population needs, looking at provider characteristics, and it was one of the hardest databases to get was actually our primary care provider database. What are the health system delivery, looking at hospitals, their utilization, physician billing, public health, and city data, so many data sources. We actually worked with the University of Ottawa to develop an interactive tool to forecast health human resource needs, and so we've got a nice robust model that we're going to be able to use moving forward, recognizing that there are many changing factors that affect your health human resource needs, so we feel confident in that moving forward. And then we also did some very detailed geographic mapping right down to the neighborhood level to look at population needs on a variety of characteristics. And this was going to allow us to very specifically target our interventions. I'm going to show you a couple of examples. So this is maybe a little bit hard to read, but these are maps of central Toronto and our 5 subregions and our 77 neighborhoods. And you can see that in this map here, you've got, we've looked at the folks with the lowest income, and in the purple and green dots are our comprehensive primary care teams. So you can see that where the lower income areas are and where the teams are don't always match. And this is partly due to the evolution of Toronto over time. The map next door is a map of the use of interprofessional teams and the highest SAMI scores. SAMI scores are scores of patients' their utilization of primary care based on their chronic disease burden. As you can see, again, there's not a match of their high SAMI scores and where the teams are. So we wanted to use this kind of data mapping to be able to understand when we did put 5 new teams in, we actually targeted them to those green and pale areas of lower income and higher chronic disease burden, so very specifically targeted. So, as Pauline mentioned, we really needed to make sure that our local leaders could come together and provide an infrastructure to support primary care, the change that needed to happen, and also to implement the targeted investments. So during the first year, we put together with agreements with our hospital resource partners, as Pauline mentioned. In each of the 5 subregions, we had a primary care clinical lead, a primary care manager, we had a project manager, and we had a manager for the most complex patients. And we also looked at developing some of those priority projects across all 5 subregions. As I mentioned, we partnered with local academics, so some of our University of Toronto colleagues were the ones that help us get this very detailed data. And this regional support structure really allows us to use the data to target the funding, to put in performance management and develop annual work plans so that we can regularly report on our work. I think the most important thing here is, as we've seen in many presentations, the growing demand for care, the shrinking resources available, so we're going to have to invest wisely. So we've had some considerable investments and created lots of momentum, but we've had a change in government, and that continued investment is likely going to drop. So we need to really move to co-designing, building on existing resources so that we're optimizing the funds that are being put into healthcare. And I think it's important that we have a way of reviewing annually what we have invested in, what have we achieved from it through a very careful evaluation so that we can either tweak or look at where do we need new investments. So some of those include developing a primary care database, which we never had before. HealthLinks is a way of providers working together around the most complex patients. Pauline did a workshop this morning on SCOPE, schemaless care, optimizing the patient experience, where family physicians have one number to call to speak to a nurse navigator, a home care coordinator, a general internist, or a radiologist to be able to access care in a timely way to avoid using the emergency department. And then we have other ways like SPIN and TIP that allow family doctors to tap into some of this team-based care on a just as needed basis. We've invested in some new interprofessional teams based on already existing resources. We're really working hard on digital care around e-consult, e-notification, connecting providers through the system, so no matter where you go in the system, your provider has access to the care that you've been receiving. We also have local healthcare connectors which attach unattached patients. And then looking at system integration, so making sure that our primary care is part of this complex system, and that although our system is changing, that through technological advancements and resource investments, providers are able to meet the needs of their patients, and that they're making sure that primary care is playing a key role in the evolution and adaptation of our health system, because we are the ones that are cheaper. So we have to be an integral part of that system. And so embedding care coordination in primary care, expanding palliative care, these are some of the things that are going to enable us to be more effective. Of course, having a monitoring system that allows us to measure what we've done. We're constantly looking at new metrics. We've developed a dashboard, and so that we can obtain results on an ongoing basis. Here's a picture of our dashboard, looking at all the projects that we're doing. Green is good, yellow's okay, red, we got to find out what's not working there and figure out how to make it better. And then looking at what are the key transferable learnings from this. So there are many elements that are transferable to assist other health systems facing these challenges. I would say, as Pauline talked about the approach to engagement, we have to engage our patients and our providers in building the system. And looking at, through these difficult transitions, how do we strengthen communication and coordination? What are some of the successful approaches to spread and scale of already existing successful, promising local initiatives? We're a bit tired of piloting. We need to take our pilots and spread and scale. How do we get better uptake of digital tools? And how do we make sure that we're always using a robust data analysis framework to inform our care? So thank you.